Okay, think about this for a second. Every single voluntary movement you make, blinking, walking, even just breathing, it all hinges on this tiny, incredibly precise conversation happening between a nerve and a muscle. It's this fundamental dance of signals happening constantly, perfectly timed. But what if you could medically and very deliberately just hit the pause button on that whole conversation? Imagine a drug that could bring on a complete but temporary paralysis. I know, it sounds a little like something out of a sci-fi movie, but it's the very real science behind a powerful class of drugs used every single day in medicine, neuromuscular blockers. So, to really wrap our heads around how these drugs work, we first have to understand the normal process that they're designed to interrupt. And all the action happens at this microscopic spot called the neuromuscular junction. It's the critical meeting point where nerve and muscle shake hands. Now, this all happens in a flash, but here's the play-by-play. First, a nerve signal zips down and releases a chemical messenger called acetylcholine, or ACH for short. This ACH then jumps across a tiny gap and plugs right into these special receptors on the muscle. When that happens, it's like throwing open a bunch of doors for ions, which creates an electrical spark called depolarization. If that spark is big enough, boom, the muscle contracts. Then, right away, a cleanup enzyme swoops in, gets rid of the ACH, and lets the muscle relax, ready for the next command. All right, so that's the normal process. Now, this is where our drugs enter the picture. Neuromuscular blockers are designed to specifically target and disrupt that elegant little four-step process right there at the neuromuscular junction. So what do they actually do? Well, to put it simply, they stop the muscle from contracting by getting in the way of acetylcholine. They don't stop the nerve from firing, and they don't do anything to the muscle itself. They just act like a bouncer at the club door, blocking the message from ever getting through. Now, this brings us to an absolutely critical safety point. Let me be really clear. These drugs cause paralysis only. They do not make a patient unconscious, and they do not block pain. I want you to imagine being fully awake, fully aware, able to feel everything, but completely unable to move a single muscle. That's why these drugs must always be given with proper anesthesia and pain medication. It's non-negotiable. So it turns out not all blockers achieve this paralysis in the same way. They pretty much fall into two main categories, and each one has a completely different strategy for shutting that muscle down. Let's call them the two tactics: depolarizing and non-depolarizing. The real difference comes down to their game plan. Depolarizing agents basically jam the signal. They overstimulate the receptor until it just burns out and gives up. Non-depolarizing agents, on the other hand, are much more direct. They just physically block the receptors so acetylcholine can't get in at all. Let's kick things off with the depolarizing agents. And really, in clinical practice, there's only one major player here: succinylcholine. So it works by pretending to be acetylcholine. It binds to the receptor and makes it fire, which leads to this brief, visible period of muscle twitching you can see on the patient. We call that fasciculations. But here's the trick. Succinylcholine doesn't get broken down nearly as fast as real acetylcholine, so it just sits there, keeping the receptors stuck in the on position. The muscle membrane can't reset, and that leads to a state of complete paralysis. But, this powerful effect comes with some pretty significant risks. It can cause a dangerous spike in blood potassium levels, which is called hyperkalemia. It can also cause a slow heart rate, muscle pain after the procedure, and in some rare cases, a condition where the paralysis lasts way longer than it should. But the complication that everyone really fears is something called malignant hyperthermia. And malignant hyperthermia is no joke. It's a rare but life-threatening emergency. It's this hypermetabolic state that gets triggered by succinylcholine in people who are susceptible. It causes a super rapid rise in body temperature, severe muscle rigidity, a racing heart. It's a true crisis. It has to be recognized immediately and treated with a specific antidote drug called dantrolene. Okay, now let's switch gears and look at the other team, the non-depolarizing agents, like Rocuronium and Vecuronium. Their strategy is a lot more straightforward. They act as what we call competitive antagonists. The best way to think about it is like a key that fits perfectly into a lock but just won't turn. They sit on that receptor, physically blocking acetylcholine from binding. So no depolarization happens, and therefore no contraction. Simple as that. Now, these agents have their own set of risks, though. To be fair, they're generally considered to have a safer profile than succinylcholine. Some of them can trigger histamine release, which can lead to low blood pressure. And of course, just like any neuromuscular blocker, if they're not managed perfectly, they can cause paralysis that lasts too long and with it, difficulty breathing. So let's put them side by side to really nail this down. For mechanism, succinylcholine overstimulates, while rocuronium just blocks. The initial effect? That's a dead giveaway. Succinylcholine causes those telltale muscle twitches, the fasciculations, while the non-depolarizing agents just lead straight to paralysis. And here's the big one. You can't reverse succinylcholine with another drug. You just have to wait for the body to break it down. But the non-depolarizing blockade, you can actively reverse it. So, with all this complex pharmacology, when do doctors actually pull these powerful drugs out of the cabinet? Let's take a look at how this all applies in the real world in a clinical setting. Well, their main use is in anesthesia and emergency medicine. Succinylcholine's incredibly fast onset, we're talking under a minute, makes it perfect for emergencies when you need to get a breathing tube in fast. That speed is the trade-off for its risk profile. The non-depolarizing agents, on the other hand, are the workhorses for longer surgeries. They give surgeons a perfectly still and relaxed operating field to work in. And in some pretty rare cases, they can be used to control the severe muscle spasms you see in conditions like tetanus. And, like we mentioned, the non-depolarizing agents have an off switch. We can actually reverse their effect. We do this by giving a different drug that stops the cleanup of acetylcholine. This basically floods the zone with the body's natural messenger, which can then outcompete the blocker, kick it off the receptors, and get those muscles working again. All right, so let's end with a little thought experiment to bring this all home. A patient needs a breathing tube placed, and fast. They're given a drug and you see a few seconds of muscle twitching all across their body, which is then immediately followed by complete relaxation. Now, based on everything we've just talked about, which class of drug was used? And what's the physiological reason for that initial twitching? See? It all comes back to understanding the mechanism.